Kevin Burns. I'm an interventional radiologist. We are located in Mission Viejo, California. So we're the first site in California to go live with the Histotripsy and Histosonics platform. Currently, me, my other partner, Dr. Tan, and my other partner, Dr. Badman, are performing this procedure. Dr. Tan may walk in intermittently. He's actually performing a histotripsy currently. I'm just kind of doing the presentation kind of from our control room. So histotripsy is been a technology that's been kind of under research for a long time. So the research first started at the University of Michigan in the early 2000s. So it's not something that's brand new. It's something that's finally been now harnessed to be able to be used for a safe and effective treatment. And so the company Histosonics has pretty much acquired all of the IP related to this. And so they're developing this device called the Edison, which is able to deliver histotripsy currently into liver tumors, and there'll be other organs coming soon. And we can talk about that later if people have specific questions just about that. So histotripsy is a mechanical disruption of tissue that uses ultrasound waves that focus on a small point that go in to rapidly expand all the little microscopic air bubbles that are present throughout your body. And what that does is it mechanically shears the tissue in the tumor in order to completely disrupt it. This is just a little animation of what would be happening kind of on the inside of the body as the histotripsy is going on. So this basically rice-sized little grain bubbles that's precisely targeted into the body can go in to destroy any sort of tissue. And as you can see kind of in this video, it doesn't damage any of the tissue surrounding it. So there's no entry or exit dose. And as you can kind of tell here, the margins are very exact, meaning there's not a gradient effect which is where you're trying to treat, the whole area is dead, and then anything you didn't treat is not dead. So there's a really defined margin, which differs a lot from other therapies we do, such as microwave ablation or radiation, where there's a kind of a gradient where the center may be dead, and then there's less dead tissue on the outside. And this is really a mechanical disruption. So this differs from other therapies, which involve either heat, cold, or radiation, because those are temperature or ionizing radiation, and they have kind of different effects on the body compared to histotripsy. So this is the image on the right is what the arm that delivers the energy actually looks like. There's an ultrasound transducer in the center of it, so we can see. And then this conical shape has all these different elements that generate the sound waves, and only where they all meet at the focal point, that's the only area that has any sort of energy deposited onto it. So anything in the middle, so say this machine was on, you could actually kind of put your hand up near the transducer and you wouldn't feel anything because the force is really only happening where the focal point is. So this is high intensity sound waves that go in and destroy any sort of tumor that's currently in the liver. The trial for kidney will be starting, and there'll be a trial for pancreas. So this is going to come to other organs, but currently we're performing this on liver tumors only right now. This is also a non-invasive procedure. That means there are no incisions. The procedure is not sterile. It is done in a operating room or a hospital environment because you do need to be kind of put to sleep for this procedure to make sure that you don't move at all. And so that also means that generally you don't need antibiotics afterwards. There are certain patients who do need antibiotics, but there's really no risk of bleeding as well because there's no incisions. And the recovery is going to be a lot less as well because there's no incisions or major damage to recover from at that point. And so this, so when you're asleep for the procedure, a big it's called a water bath. This membrane sits on top of your body. We fill it with water, and that really makes the treatment head kind of conform to your body. Sound transmits, or ultrasound waves transmit very well through fluid, but not through air as well. So we have to get rid of all the air from the treatment head to your body. So this big water bath, and I'll show a picture of that later, goes on top of the patient to deliver the energy. So this is just kind of another animation of what would be happening on the inside of the body. So this is highly magnified, but this is kind of what the mechanical bubble cloud kind of looks like on the inside of the body. So this would be happening in the liver, and we could visualize this in real time on ultrasound. This is a animation of actually a treatment happening. This is just inside of a kind of a water bath, but this is going to show you the bubble cloud. So on the bottom left corner, you can see this voltage number. So as we turn up the voltage, you can see all of a sudden the histotripsy happens. And so this is happening at this one focal point inside of your body. And every tumor, everyone's tissue is going to have a different voltage that we have to perform this at. And so this is customized to every patient, and we actually see this live. the treatment is also audible because these are sound waves. If the therapy is happening, we actually can hear a tone kind of being emitted from your body. And if we don't hear that sound, we know that we don't have enough energy in order to destroy your tumor. This is another animation kind of showing what the doctor, what we will see on our screen. And this shows an animation of histotripsy we performed on a piece of, this is a piece of liver, cow liver that's outside the body. You can see that we plan this sphere, or this is a simulated tumor. We plan this big sphere around your tumor. And this is sped up, but this is what the treatment would look like inside of your body, where the Edison machine moves the histotripsy point around your body in a pre-planned approach to go around the tumor. And they on the right side of the screen, this is what's happening is inside of the tumor, where everything is really mechanically destroyed instantly. And so it moves in the shape in order to kind of encompass the entire tumor and also a margin. And this is sped up quite a bit, but that's what would be happening inside of your body right there. And then afterwards, they're going to show that they're going to cut this open, and you'll see what the inside looks like. And again, this is a piece of cow liver that was completely treated with histotripsy. And you can see that the whole thing is liquefied. And so this is instant liquefaction, meaning instant cell death. So none of the cells are viable. Let's see, my PowerPoint crashed. Okay, let's open that again. Too much excitement. Didn't like my PowerPoint. Let's see. Okay, so we saw that video. So this would be a microscopic image of that. So say we treated a piece of a tissue in a patient, and then we did a biopsy of it and sent it to a pathologist. They would see the treatment zone, which is in the center of the screen, and then there's this kind of exact border. So whatever we're treating, we're killing, and then there's kind of this precise border where there's not any damage to things around the tumor, what we're treating. Obviously, we want to get what's called a margin, or if a tumor is close to something, we may damage something, but it's very, very precise treatment. That's what an example of this. So it shows that really where you're treating is all dead. It's liquefied. Really, a pathologist actually can't tell what tissue it came from because it's all this kind of just liquefied material. They can tell it's cells, but they couldn't tell what organ it had come from because it's so liquefied. This is kind of an example of a treatment of not in humans, but in cows when they were testing this. And so these are just pictures of the treatment cavities. And what you can see is that this therapy actually will preserve some of the large ducts and blood vessels that are present in the liver. So that differs from all the other therapies that we offer. The reason it can do this is they can tune basically the power of the bubbles in order to not damage these structures that have a lot of collagen in it. It will kill off any of the viable cells there, but it'll leave kind of the ducts and the structures intact. And so that they can still provide blood flow to the area in the liver. And this is just an example of what a cavity would look like. So they basically can wash out the entire ablated area, and you can see that some of the ducts and the blood vessels are still present inside of this. So this differs from other things like we do microwave ablation, cryoablation, radiation, where it kind of just destroys everything and causes necrosis in the area. So this is another differentiating factor from that. This is an example of a patient who had histotripsy in one of the trials. And on the MRI, you can see that there's this white line that runs to the tumor, and that's a blood vessel that maintained intact. So we were able to actually treat through the blood vessel, but not damage it. And so it was kind of maintained intact. So that's a unique feature of histotripsy and histosonics, which is not available with other technologies. So with histotripsy, we aim to provide instantaneous and complete tumor destruction. So the tumor dies instantly during the treatment. We think that, or there's basic science to show that we can alter the microenvironment in the tumor and potentially the immune system recognition of the tumor. And we can do this to reduce the amount of disease present in patients and also improve their quality of life with very minimal intervention because this is non-invasive. So there's been a lot of studies on immune modulation related to histotripsy. So these are all done in animals. And so that doesn't all directly apply to humans. So there's a lot of research still going on for this. But in animal models, histotripsy has been shown to induce an immune infiltration of the treated area. So this is just an example of a tumor on the left and then a tumor that was treated with histotripsy on the right. And the staining just shows that there's increased amounts of T cells basically that have infiltrated the tumor. And these are the cells that you want to help recognize tumors so that can go and kill tumors either elsewhere in the liver or elsewhere in the body. And so in kind of one study that compared the amount of circulating tumor infiltrating lymphocytes compared to radiation or RFA, it was much, much higher in histotripsy. And so that's a differentiating factor from some of the other local therapies. And so for the histotripsy procedure, just give me one. All right. Sorry. So for the histotripsy procedure itself, this is done, like I said, under general anesthesia. So that's one thing to know. That may not be always a requirement. It's currently, it's not necessarily a requirement, but it's currently makes the procedure much better and safer and faster for patients, which means that we can treat potentially more tumors because we can keep you in still for longer. So this is designed as a single therapy session. Obviously, if somebody has multiple tumors, that may require multiple sessions, but we can treat multiple tumors in one procedure. It non-invasively liquefies the tumor into this acellular lysate, meaning the cells are just kind of destroyed. They're not viable, and it turns into that liquid that you saw in that example. There's really minimal to no pain. Some patients can have pain depending on tumor location, but overall pain is very, very minimal compared to other therapies. And the treatment's also very precise. We talked about that before, where we're only treating the area we think we're treating, and there's not really a gradient where there's some damage to surrounding structures. We can draw the margins, and we'll show that later on the ultrasound of a tumor, and we're very, very precise in that. And we talked about there's a potential to augment the tumor microenvironment. There's also the potential to reduce the intratumoral pressure. So a lot of tumors of different tumor types can have very high resistance, meaning the tumor is kind of very stiff. So when you give chemotherapy or other medications in the bloodstream, they may have a difficult time penetrating the tumor because there's so much pressure inside of the tumor. So if you can partially treat a large tumor and kind of decrease the pressure, that may allow better drug penetration to provide better treatment in combination with chemotherapy. And I don't know if I mentioned it yet, but in most of these patients, we maintain all systemic chemotherapy. So because there's no incisions, there's no real need to stop any sort of chemotherapy that you may be on. So this is really an adjunct treatment. It doesn't necessarily replace anything, and it doesn't, you don't really lose that much because say you're going to have surgery or radiation, you may have to pause your chemotherapy for a while because there can be a lot of side effects when they're all done concurrently. But with this, you can maintain all of your chemotherapy or any systemic medication you may be on. This is what the machine looks like currently. So this is the device that we're using right now to treat any liver tumor. And so a patient is placed under general anesthesia. So that means you do have a breathing tube. You are completely asleep. The reason we do that is that your liver sits right under your diaphragm, which is your breathing muscle. So every time you take a breath, your liver moves up and down. So with anesthesia and certain tactics, we can minimize that movement or eliminate it so that the tumor can stay in one place and we can deliver a more effective therapy. So the machine, which is called the Edison, is this big machine on the right. All the power happens in this big base unit. This is mobile, so it can be moved around. The console here, this is where we can load in your MRI, your CT, and we can use that with the ultrasound to kind of fuse together to make sure that we're targeting the correct location or trying to reach tumors that are harder to see. We use all the software on the machine to plan out our treatment. And then the arm that you can see will move this treatment head, angle it, move it around in order to deliver the therapy throughout the tumor. The water bath is what you can see kind of sitting on the patient here. And this gets rid of all the air between the treatment head and your body. And so that the treatment can go in and deliver effective therapy. So this procedure, like I said, is performed under general anesthesia. We often provide a dietary handout ahead of time. The reason is to prevent some bowel gas. So you will go on a special diet to decrease the amount of gas that's present in your intestines, because sometimes that could be in front of the colon or be in front of the liver, and that could alter our ability to see tumors. And so like I said, during the treatment, this soft flexible membrane goes on top of your liver. We fill that with this special called degassed water. So it's water that has all the air taken out so that the sound can go directly from the treatment head through this water and into the tumor. And the water helps, transmit that. And there's no incisions, no radiation. Again, that's one of the other benefits of this. And we use live ultrasound, so it's built into the treatment head so we can actually see what we're treating as we're treating it. And we can fuse this with any existing scans that you have to make sure that we're treating in the correct location. Therapy times can vary. If you're treating one tumor, obviously your procedure will be much faster. But often now we are treating many tumors at once. And so procedures, I would say on average, if we're treating multiple tumors, are going to be probably, over 2 hours for these procedures. If you were just treating kind of one tumor, the actual time that the ablation is happening could be 20 minutes or so. But there is a lot of setup before that and planning. So this is just a close-up of kind of what this water bath looks like kind of on a patient. So you can see that this water bath kind of goes onto the body. And when you put the water in, it kind of conforms to the surface, and you can see kind of inside of that, there's the treatment head, and we're using this to image. So this is all that contacts your body during the therapy. This is a video showing what the doctor would be seeing during the procedure. And so this is a simulation in a phantom, meaning not an actual patient. And you can see that on the screen on the right, this is what our console looks like. These are all kind of the devices we use to program and move things around. But you can see that kind of the red circle, that's going to be the treatment volume. And the treatment goes conic or kind of spirals around through this in order to deliver therapy in this very precise point all the way. You can see that little X that's in there. That is kind of where the therapy is happening. And you can see instantly afterwards on ultrasound, we can see that it looks completely different than it did before. So this is really an instant, kind of an instant treatment. So after the procedure, you may have a little bit of pain or discomfort. And it really depends on what's treated. I would say most patients do not have pain, but some definitely do, depending on the location. We send almost all patients home within a few hours after the procedure. In some patients do need to stay overnight, but I would say in general, and that'll be patient specific. In general, patients, this is designed to be an outpatient procedure, and you can go home usually within a few hours after the procedure. Symptoms after the procedure, usually within the first couple days, often the next day, you can have some post-treatment symptoms. And that's fairly common. That usually is going to be a fever or a low-grade flu-like illness. That happens with a lot of other therapies we do as well. And that's really expected. That's your body is having a reaction to the dead tissue, and it's kind of using its immune system to go in to invade and clean that up. And so that causes an inflammatory reaction in your body, which can lead to fever, low-grade flu-like illness. You could even have some muscle aches. Just feel like you have, under the weather, or, kind of what you feel like maybe if you've got a vaccine and you feel a little ill the next day or two. That's pretty normal with this procedure, and that's really expected. And so looking at treatment in real patients, so the first trial was called the Teresa trial. This was done in Europe, and this was just really to look to make sure this was safe and effective. And so this was done, several years ago, and so this proved that this procedure was safe. This is just an example patient from this trial showing. You can see the white circle here. This was a tumor that was treated. They did an MRI 1 week later, and you can see that now that entire area is all black. And then you can see that on the next follow-up imaging on 8 weeks, you can see that everything is still kind of all black and starting to get smaller. So this trial showed that this procedure was safe and effective. And later, we had the Hope for Liver trial. And so this was done in Europe as well as the United States. And the goal of this was to evaluate the efficacy and the safety of specifically the histosonic system to treat any sort of tumor in the liver. That could be a primary tumor, meaning cholangiocarcinoma or hepatocellular carcinoma, or that could be a metastatic tumor to the liver. So this had a total of over 40 patients, and they did follow up at basically 1 day, 30 days, 6 months, 1 year, and annually all the way out to 5 years if possible. And so this basically showed that this procedure had a high technical success. So that's very important. Can we target a tumor and accurately treat it? And so they had a technical success rate of about 96%, that they were able to destroy the targeted tumors. And that was defined by patients who had an MRI done within a day and a half of the procedure to make sure that everything was targeted. And then they also looked to make sure this procedure was safe. That's also important when we're offering any new therapy. We want to make sure that this is safe. It's not going to cause any other issues related to the patient. So overall, they found that this procedure was very, very safe. There was only a few patients who had some complications from the procedure. One patient in this did have an infection. That patient had a biliary stent. And those are often the patients that we do give antibiotics to prior to the procedure to prevent that from happening. One patient did have pain and had to be admitted to the hospital. And in this study of the 44 patients, one patient actually did pass away about 37 days after the procedure. This patient had many tumors throughout the liver, and they think that it's likely related to just the disease progression itself rather than the procedure because only one lesion was treated. But they do have to report that in the trial that one patient did pass away about a month or so later. These are some patients that were treated in this Hope for Liver study to prove that this procedure was safe and effective. And on the very, very left of these are going to be the images of the tumor prior to. So on the top left image, you can see the small white dot here. That's one of the tumors. They did an MRI. Of course, we wouldn't image a patient like this every day. This was just done for the trial. And you can see on one day, it shows that the treatment cavity encompasses the lesion. There's nothing there. And you can see by 1 month, it's starting to get smaller. And by 6 months, 1 year, and 2 years, it's almost gone that you can't see it. Same thing with this other tumor. On the bottom left image, you can see this dark spot here, kind of pressing out of the liver. And then you can see on the 1 day, the 1 month, and all the way out to 2 years that area really involutes and kind of goes away. And so the strengths of histotripsy, one is that it can preserve the liver parenchyma, so it doesn't cause a lot of damage to the surrounding tissue, and it preserves the ducts and the blood vessels that may run through where the tumor is. It's having good results on follow-up imaging. So when we do follow-up imaging, we're noticing that the treatment cavity is really involuting or kind of disappearing or going away. When we do other therapies such as radiation or microwave ablation, often the treatment cavity will stay there kind of forever. And there can be some issues, on follow-up imaging, trying to decide if there's still any active tumor or if it's really just the post-treatment changes. So that's another benefit to this. It's also non-invasive, so there's no incisions, and which means there's decreased risk of complications, infections, and bleeding. And it's also an immediate therapy. So for a single tumor, it's a one-time treatment that immediately kills the tumor, which is different than other things such as radiation, which may require multiple sessions, and it takes a while for the tumor to actually die after the radiation. So this is looking at all the cases that have been performed in the country. This is probably up to date as of 3 days ago. And so in the entire United States, there have been 352 patients successfully treated with the Edison system, treated a total of 634 lesions. There's currently 20 centers offering in the US. There's 20 hospitals offering this procedure right now. And there's 36 active physicians in the entire country performing this procedure, and we have 3 of them at our site. So you can see across the entire country, the most common tumor type being treated is going to be colon cancer that has spread to the liver. The next is going to be neuroendocrine tumor that has spread to the liver. And then the next after that will be hepatocellular carcinoma or liver cancer, and then pancreatic cancer, breast cancer, and cholangiocarcinoma. The most common is to treat one lesion. So you can see about half of the patients had one lesion treated, but there have been patients who have had up to 9 lesions treated in one session. And I think the numbers of the patients who we treat 4, 5, and 6 lesions is going to be growing because there's been some software updates on the machine that make the treatment a little bit faster. This procedure is performed by different medical specialties. So it's about half and half between a surgeon performing this versus an interventional radiologist. And if you look at the locations of tumors, we're really able to treat all locations in the liver now. At the beginning, we were really just treating the bottom of the liver. But if you look at the distributions now, we are able to treat all lobes. So the liver is divided into 8 segments, and this is defined by what blood supply goes to the area. And so that's often how we classify tumors based on their location. The most common area to treat is going to be the left liver and the bottom of the right liver, but we are able now in some patients to treat the top of the right liver, and there'll be other future innovations coming to the Histotripsy platform later that will help us treat even more locations and more patients. So if you look at just our experience, I'm not going to show any of our own cases, just in case any patient may be watching. I don't want to show any data, but I'll show our numbers here. We have completed 89 cases as of yesterday, 90 as of today, and we've treated a total of probably about 200 lesions after we finish our procedures today. Our most common tumor type is also going to be colorectal cancer, followed by breast cancer, and then neuroendocrine tumor and pancreatic cancer. So most commonly, patients are having metastatic disease to the liver, and we're offering this therapy in order to decrease the amount of tumor in the liver and potentially kind of alter the tumor microenvironment, and potentially in some patients, try to induce this immune effect. So for the future of histotripsy, so currently we're treating liver tumors. The trial to treat tumors that are in the kidney, so renal cell carcinoma, has started in the US. We will be participating in that shortly, and that should be done by the end of the year. And hopefully, once those results come out, this will be offered commercially to patients who have kidney cancer. The trial for pancreatic tumors will be starting in Europe later this year, and then that trial should come to the United States in 2025. But if you look at this technology, there's, it's a non-invasive way to destroy things. This can really go to multiple areas of the body. So kind of currently we're treating things in the abdomen, but I think as time goes on, we're going to expand this into multiple kind of other organs in the body, such as the prostate. That'll be one that comes soon, potentially the thyroid, the breast. So there's a lot of future for this, and they're even working on a device to help treat through the skull so that things in the brain could be treated at some point. And that stuff's still a long ways out, but it's something that's at least in the pipeline to kind of harness this technology. And that's all I've got. And I think we'll open everything up to questions at this point. Chelsea, were there any questions in the chat? Let me pull that up. Okay, let's see.
Thank you, Dr. Burns. We definitely do have a couple questions in the chat, but I also want to open it up to our audience with any questions they might have. So does anybody have any questions? Do you want to?
Sure, I'll ask if that's okay.
Absolutely, go ahead.
First of all, I just want to make a comment, like, sign us up. This sounds amazing. I wanted to ask, is there still, I've read that still size is an issue on various tumors, and I'm just wondering where you're at with that now. Are you still?
Yeah. So let me just pull up share. So yeah, so for any tumor, if you're going for what we call curative intent, meaning you want to completely destroy the tumor, there's a lot of evidence for even surgery, microwave ablation, that anything over 3 centimeters has a higher chance of a recurrence. And so that's if you're going for a complete cure. So say you have a primary liver tumor, hepatocellular carcinoma, you have one tumor. The goal is for cure, right? We're not going to just try to make it smaller. We want to cure the whole thing. So if you had a tumor that was larger, the chance of having a cure is much lower. That goes up with size. Currently, with the software now, the biggest single sphere we can make is 4 centimeters. So if you have a 3 centimeter tumor, you really want to do a 4 centimeter ablation in order to get margins, meaning you want to get a little bit extra to make sure that there's no small tumor cells kind of in that area. So if you had a tumor where we're going for cure, you can do multiple treatment sessions inside of that. But if it's a bigger tumor, there could be other things that may be better options. But we definitely do histotripsy on lesions that are much bigger than that. If the goal is not a cure, but decreasing the size of tumors over time. So say you have disease that has spread to the liver, at that point, you may not have an option for a cure, right? You want to just get rid of as many tumors as possible. And so at that point, if we can start making the tumors smaller or decrease their intratumoral pressure, it may help chemotherapy penetrate. So we definitely treat bigger tumors. We definitely have treated bigger tumors. You could have a tumor that's 12 centimeters, but it's causing so much pain because it's on the edge of the liver. And, maybe treating half of it is enough to shrink it down and prevent you from having that pain.
Yeah. So our diagnosis is cholangio with mets to the liver. This is for my sister, and she's on the call on this webinar. I'm just wondering then, if you got it small enough, could there be an option for resection after that?
Yeah, every patient is going to be different. Obviously, I'll just speak in general. There are often local therapies that can be done for cholangiocarcinoma in order to get patients to surgical resection. And that could be a combination of chemotherapy, radiation. There's another procedure called Y90, which is radiation that's injected into a catheter. And there's definitely studies showing that you can get unresectable patients to resectable. So that's definitely a option with this. But it would depend on, how many tumors and the location and everything like that.
Thank you.
And we definitely have cholangiocarcinoma patients who have many, many lesions, and we're treating them over multiple sessions, trying to get rid of as many of the metastatic lesions as possible.
Excellent. We've already submitted our stuff, so we're waiting for a consult. So thank you.
Okay, perfect. And then I was going through the chat. If anyone else wants a question, I'll go through the chat also.
Thank you.
I have a couple of questions.
Sure.
So First is, so you kind of answered the size constraint question. I have in my left lobe 5.8 centimeters by 4.5 centimeters, which is actually roughly about half of what it was when I started. And I'm no longer, I'm having bad side effects to the chemo. And I also was on, I did 1 dose of the immunotherapy, gemcitabine, or sorry, that was the chemo, Imfinzi.
Okay.
So all those options are kind of off the table for me now. And because I'm losing my vision and other things. So I'm looking to this as a potential possibility for me. And I was concerned about the size of my tumor being too big. Is this viable for my type of
I'll say it's
situation?
going to depend on the location also.
Okay.
So because if it's confined to one area of the liver, there could be something else that's better. And obviously, we offer everything. So, you know, if you do talk to us and you're really interested in histotripsy, we may say, actually, this other therapy is better for your specific case. And we can go over everything. We definitely have patients who have lesions bigger than 3 centimeters that we are treating and shrinking. This procedure can also be done multiple times. So
Okay.
it's not like this can just be done once and that's it. As long as we can see the tumor, there are some limitations, especially when you've had a lot of treatment. You know, as long as we can see it accurately with ultrasound, it could be treated even if it's a bigger size. And that means that it could be multiple ablations in the same session of the lesion to cover everything, or it could be ablate as much as we can, get the follow-up MRI, see if anything's left, and then go after it kind of at that point.
Yeah, I think one of the biggest concerns is that the tumor seems to straddle some of the critical
Structures, yeah.
blood vessels and structures within the lobe. So
Yeah, so especially, so say someone has a tumor that's central like that, and it's going to be compressing a duct or something, that may be an area that we want to go after in order to prevent that from getting worse and causing an obstruction of a blood vessel or a bile duct.
sure.
So we can definitely go in and shrink that. And, you know, if you see somebody who reviews your case here or anywhere else, then they can talk about this therapy versus other therapies, just to
Okay.
make sure whatever we're doing for you is the best thing.
Okay, that kind of leads me into my next 2 questions. So as far as what's the best way to get a review of my case?
Yeah, so there's a lot of I don't know where you're located, but there's a lot of locations, like there's 20-ish sites in the country. So if you're, I think they have all the locations listed on their website as well. So there may be a location that's,
Yeah, no,
obviously we're happy to.
specifically with you guys. I'm
Okay, yeah.
actually, I share
Sure,
time
so
with
maybe,
Arizona and San Diego.
okay, so maybe Chelsea can send, is there a way to send an email to people that register just with like the link to the website? So there's a website that has a patient intake form. We have a nurse navigator that is specifically dedicated to this procedure. So they have an email address. It's histotripsy@providence.org. But there's also an intake form on our website. I think if you search Providence Mission Hospital Histotripsy, we made a website about this. And you can submit all your information. We do need to get your imaging records, and we probably want at least 1 note from your oncologist or some doctor just with all your history detailed so that we can review that as well. And then once they have all the imaging and everything, they'll set up just a telemedicine consultation with us. And it'll either be me, my partner, Dr. Tan, he's actually here. He's here listening too. And or Dr. Babin. So we're all doing consults on all these patients. And so that's really the best way.
Okay, great. Last question. And I'm sure probably other people have this question as well. Insurance, as far as coverage.
I would say, yeah, coverage for insurance. There's no issues if you're Medicare. So that covers a lot of patients because it is a Medicare approved procedure. Commercial insurance, it really varies. And it's hard to predict. We definitely know which carriers are really not covering it as well, but there's a lot of variations. Even if you have one insurance, depending on what state you live in or location, it may be different than another patient. So it's hard to generalize. There's definitely patients this is not covered, but there is commercial payer insurance coverage for this. As we get more data, and there's going to be some more papers coming out to support the evidence for this, we may have some more evidence to get those insurance companies who still classify this as experimental to overturn that.
Okay.
So if you give all of your information to the nurse navigator here, before they like put you through the process, they'll try to submit to your insurance and make sure it's going to be a covered procedure for you.
Okay, great. Thank you very much for your time.
Dr.
And then I'll
Burns,
just, oh
we
yeah,
have a
go ahead.
couple questions in the chat. I'm gonna just read some of them off. We already
Sure,
answered question.
I can scroll through from the top too.
Okay,
I did not see the article that was posted about pseudoprogression from immunotherapy, but so pseudoprogression definitely happens with immunotherapy. So say you have a tumor and you go on immunotherapy, things can actually get worse on your first imaging before they get better. That could happen with this procedure as well. I don't know if we have enough data on enough patients to make a generalized statement on this. But if you're going to, or so in some of the patients who we think are having immune responses, at least in the trials and current patients, it was shown that on very, very early MRIs done, there's a lot of enhancement, a lot of uptake of the contrast that they get for MRIs and tumors that weren't treated. So that in theory would mean that those tumors could swell because the body is kind of infiltrating them or doing something to them. So that definitely could happen. I don't know if it'll happen with the same frequency as immunotherapy, but I don't think it's out of the question kind of after this procedure. We don't have enough data in humans to make a generalized statement on which tumor types will respond better as far as this abscopal effect goes, or who's going to benefit from that, or does this need to be paired with a certain medication or a certain immunotherapy to enhance the chance of that happening? There is going to be basically a registry called Boombox where that'll be starting maybe later this year, where patients will be asked if they want to participate. It doesn't require anything. This means that we're going to collect all your data from all the sites that are doing this procedure, get every medication you're on, try to get all your labs, all your follow-up labs, and all your follow-up imaging to see if we can figure out which patients are having these off-target or abscopal effects, and to make sure we can harness that, provide that for the best for every patient. Does the liver regenerate? So the tumor or the tissue that's destroyed kind of involutes, meaning it gets reabsorbed. And so the liver itself does regenerate. So because the tissue is getting reabsorbed, there will be kind of liver that does fill in kind of that area. And that kind of goes away. So the tumor gets smaller over time versus something like a microwave ablation. When you do a microwave ablation, you microwave the area and it just stays the same size forever, and it just kind of turns into scar tissue. So with this, it liquefies and then kind of goes away, and then kind of tumor or liver just kind of fills in the void there. Criteria for this procedure, every patient's going to be different, so it depends on what the goals of therapy are. If you have metastatic disease to the liver, it can be, quite common that the reason, people end up passing away is from liver failure. So we want to prevent that. So if you're a candidate for any local therapy, or maybe you're not a candidate for other local therapies, this actually you could be a candidate for this just because of the non-invasive nature of this. We definitely have treated very sick patients with this procedure, and they have done kind of, surprisingly quite well with this procedure, and patients that weren't really candidates for anything else. So the device is indicated for any tumor in the liver. So it doesn't matter actually if it's benign or malignant. So if there's a tumor that can be treated in the liver, then technically this device can be used for it, even if it's a precancerous lesion. It'll all depend on the location again of where something is. If you're going to have multiple treatments, there's no real clear-cut guidelines on this. We've kind of just been waiting a month on patients. That just kind of goes to other therapies we do, such as doing procedures like Y90, where we're treating both parts of the liver. But there's no real requirements on that. Let's see. Yeah, so we've definitely done this on patients who have innumerable tumors in the liver. So it depends on the goal of therapy. If the goal of the therapy is going to be to stimulate this immune effect or just start debulking the liver, it doesn't really matter how many tumors you have. We'd have to look at your case specifically to see if there's certain tumors. So you have a lot of tumors and you're on therapy and everything's getting smaller except for maybe 1, 2, or 3 tumors. Those are the ones you want to target. So or a patient who's been on therapy for a long time, and now all your tumors in your liver are stable or smaller, and one of them is growing, or 2 of them are growing. Those are the ones you want to target. Those tumors may have a mutation or something where they're not responding to your systemic therapy now. And so if you target those with local therapy, that may allow you to stay on your current therapy and not have to change systemic therapy. The histotripsy will, I imagine, be coming to Europe. I think it just has to go through regulatory approval. The tumor type doesn't necessarily make any treatment more difficult. It's really going to depend on It's really going to depend on the location from that. Sometimes cholangiocarcinoma can be more central. If anyone has questions they want to mention as well, I'm just scrolling through the chat and answering here. So recurrences after histotripsy, so it's going to depend on the treatment. So if the tumor was smaller and the entire lesion was covered, at least on our own scans, we're seeing good results. We have a lot of patients who are out past 3 months. But if we're really debulking the liver, you're not killing the entire tumor itself. So there could definitely be some growth of the tumor that you haven't treated. Size criteria. So there's really no minimum size, but you do need to be able to see it. And so if we can't accurately localize a tumor and the tumor is very small, there could be a chance that you could have a treatment that doesn't treat the exact right location and you could miss target. So that would be one of the risks for a smaller tumor. In general, in every patient, we do a planning ultrasound prior to the procedure with one of our ultrasound techs who does the procedure with us. They'll go and make sure they can find your tumor, figure out if you're going to be on your side, on your back, in order to make sure that we can actually see it. And if we can't see it, we may be something where we don't offer this therapy because we can't accurately identify it. I would say that there's definitely a learning curve for the procedure. I think it's going to depend on the physician doing it. But there's definitely a learning curve. We're definitely a lot more aggressive now that we've done many lesions. So I would say at the beginning, it's fairly common where you're going to treat, maybe one lesion in patients, but as we've done a lot more, we are treating, many more lesions in patients. And so, there is some learning curve. The company provides a lot of support and there is a lot of training. So anyone who is offering this, I wouldn't have any concerns going to see any of the doctors who are offering this therapy currently. If a tumor is necrotic, we may want to target the edge. So say you have a large tumor. Necrotic means that an area in the tumor is dead, likely from the chemotherapy. We would really want to target the area that's viable. So on that patient, we may want to target the edge of the tumors in order to make sure that we're killing off some of the viable tumor in order to provide a benefit to the patient. So I would say for recurrences, the larger the tumor, the higher likelihood of having a recurrence. So even if you have a tumor surgically removed, the bigger the size, the higher chance of recurrence. So you could have a tumor in your right liver. You can have half of your right liver cut out. You could still have a recurrence because there could be a cell that's already moved somewhere that you can't see because it's so small, and over time that could grow back. Yeah, so say you have some precancerous lesion. So I'll generalize it more in a patient who has liver cancer. So when patients with cirrhosis or liver stiffening or liver dysfunction, oftentimes we'll do MRIs to check to see if there's any lesions. And we grade these on a scale of 1 to 5, with 4 and 5 being highly suspicious for cancer and grade 3 being indeterminate. Generally, we're not treating the indeterminate lesions now because we're putting a patient through a procedure that may or may not be cancer through an invasive procedure. But if we do now have a non-invasive procedure, that could change treatment algorithms in the future, where we may go after the precancerous or possibly cancerous lesions because we don't have to, make any incisions or anything like that. I'll just generalize. Someone asked a question about Y90. We can definitely treat patients who have had Y90. You can actually treat the same lesion. The particles when the Y90 doesn't affect the therapy. So if you had a tumor with Y90 and now it's growing back, or it's a nearby tumor, that can be treated successfully with this. I think if you've had Y90 to a tumor on one side of the liver, I think this can be actually a pretty good procedure to treat tumors on the other side of the liver, if it's appropriate size and location, because then you can prevent having even more radiation kind of into the body, which can potentially damage more of the normal liver. So someone asked about hilar or Klatskin tumors. You may have heard that word. That's generally it's called a cholangiocarcinoma that develops in the very, very center of the liver. We have definitely treated those. Other sites have treated those as well. And so that can be done. It may be something that is done in multiple sessions to get different pieces of it. And it may be something, it'll depend also if a patient has stents in place. Actually, the preference would be probably to have stents in place prior to that therapy. in order to prevent any damage to the bile duct, even though we think it's not going to be damaged. But if there's tumor cells in the bile duct itself, that probably would be damaged. And so in a patient who has a Klatskin or a hilar or center of the liver tumor, it's definitely possible to offer this therapy, whereas other therapies may not have been appropriate before. And there's a lot of physicians throughout the whole country that do have experience treating the central tumors. Depth of the tumor. So with the limitation is really going to be the depth from the skin with current devices. So currently we can treat up to 14 centimeters deep from the skin. There's actually a limitation on the superficial nature. So if a patient's very, very thin and the tumor is on the very edge of the liver, if it's too close to the skin, it actually could be not a good candidate for this therapy, because it can cause a little bit of damage to the skin if it were to be too close. There's no entry or exit dose, meaning really, like you saw just where that bubble cloud is, that's what's being killed. There's nothing, none of the sound waves going into the liver are causing any damage to anything. Every patient's gonna be different as far as location goes, but if you look at all patients in general, we've treated every area of the liver. The hardest areas are going to be anything at the top of the liver, or if it's under kind of the rib cage. We are treating through the ribs now, and the treatment can actually go successfully through bone in order to treat it, but the limitation is going to be on whether or not we can see it with ultrasound to make sure we're accurately targeting things. So patients who have we've treated patients from other countries have come for treatment with us. There is a cash price for this. I'll leave that offline, and if that's something our nurse kind of navigator can discuss everything with you for that, because sometimes that can change over time. So I don't want to give any actual number. If a patient has a biliary stent, we generally follow the same protocol we use for other liver-directed therapies, which is approximately about 3-week course of antibiotics, which starts 3 days prior to the procedure. And every institution may have different requirements, but that's the general what we use for Y90 microwave ablation or other liver-directed therapies. And so it'd be about a 3-week course of antibiotics. So can this replace surgical resection? So that's really going to depend. We think of surgery as the gold standard, meaning a curative. So we compare everything to surgery. There was a paper published called the Collision Trial that came out earlier this year, which actually compared microwave ablation, which we have years and years of experience, to surgical resection for lesions that are under 3 centimeters. And they actually showed that there was no difference on outcomes to doing an ablation versus having a surgery. So in an appropriate lesion, in an appropriate patient, I think in theory, a lot of these local therapies could replace the need for surgery going into the future. So abscopal effect, so we don't have numbers on this. We're going to want to see that the tumor markers go down more than we would expect. I think that's one of the biggest signs. There are signs on imaging as well. Usually MRI is going to be a little bit better to detect that. So if you had an MRI done after the procedure, it may show that there's more edema or swelling or enhancement of a lesion we didn't treat. And we think that may be a sign that that's the immune infiltration into the tumor. But we also want the tumor markers to go down. So say you are a patient who has been on the same chemotherapy and your tumor markers are going up, 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 and we do this therapy on one lesion. If you have many tumors, we wouldn't really expect the tumor markers to go down significantly. But if all of a sudden you see a sharp drop in the tumor markers, we think that is a patient who's having an abscopal effect. Or we have patients who are not on chemotherapy due to patient preference, or maybe they're having side effects or they're too sick for it. And if we say a patient has 20 tumors and you treat one and the tumor markers drop in half, that wouldn't be expected just by treating one tumor. So that's a sign that that patient is probably having an systemic effect. The other question is, how long does that effect last? We don't know in humans exactly how long that lasts, but there's a hypothesis it may last about 3 to 6 months or so. And then the immune effect kind of wanes at that point, similar to a vaccine where you have to get a booster. Someone asked about treating patients with hernias. We have treated patients with colostomies, external drains. So as long as it's not directly in the path that we're treating, we're usually able to treat those patients. Let's see. So if somebody's had a recent therapy, we'll usually want, like I said, we usually wait at least, a month or so after some big liver intervention, just to make sure that the liver function is maintained. And if you've had another therapy, chemoembolization, Y90, you'd probably want to have follow-up imaging after that first, so that we can accurately target any sort of viable tumor. Anyone have any other questions that they want to come off mute for?
Thank you, Dr. Burns.
Someone mentioned PRRT, so I would say that that would not limit therapy with this. PRRT is a medication you can take in the IV that has radiation loaded onto an antibody that goes and specifically targets neuroendocrine tumors. That's commonly done for patients who have liver and other tumors. So that would not exclude you from having this therapy.
Any other questions? Feel free to
Okay.
unmute and ask your question.
I had a question.
Go ahead.
Yeah, I just wanted to know if there would be, like, if you were getting a liver-directed treatment like chemoembolization, is there a waiting period in between like your last treatment and when you could do histotripsy?
It's going to depend on are we treating the same area or a different area. So say you're getting your chemoembolization in the right liver, but you have a tumor in the left liver. As long as you have normal labs, maybe a couple weeks after the
Okay.
chemoembolization, just to make sure that there's no liver insufficiency or liver failure happening, then
Understood.
that's really the only limitation.
I just want to thank you, Dr. Burns, for your time today. This is really informative, and I plan on checking it out each month. Thank you again.
You're welcome.
Thank you for joining us.
I was going to show you the machine, but they just turned it off and put it away.
Oh,
Because we just finished a procedure. But let me. Yeah, it's kind of put away. I mean, I could show you the machine. It's turned off if anyone wants to see it, but if not, we'll just answer questions.
What's the minimum size tumor that you treat?
So as long as you can see it, that's going to be the minimum size. We definitely have treated tumors. Maybe I don't know maybe the smallest we treated was like 5 millimeters or so. Just you could definitely treat smaller. You just have to be able to see it. We can utilize fusion imaging too. So say you see it on an MRI, the machine actually can take a scan with ultrasound, and then we can map it up to the MRI, and that can help guide us in the area. So say we can't actually visualize the tumor because it's so small in ultrasound, we can use landmarks from the MRI, different veins or ducts, and kind of align that with the ultrasound in order to give the therapy. So I would say the size criteria, the smaller it is, the more likely you either can't find it or you could miss target treating the area.
Well, I've got on segment 7, I've got a 0.4 by 0.4 centimeter tumor. And segment 6, they say it's resolved.
Okay. Yeah, so I would say a tumor that's that small in that location could be difficult to see. It's hard to make a general statement. So segment 7 is the top of the back of the right liver. So that location in some patients is easy to see, in some patients it's hard to see, because everyone's kind of body is different on the inside. So you'd have to kind of review obviously your case individually, but it is something that I don't think that would exclude you from anything. And we may consult with you and say, I don't think we're going to see this, but here's all these other options. Have you considered any of these as well that may provide a better therapy for you specifically?
Okay.
Timing wise, I don't know what our current timing is right now. I mean, there's definitely a wait list. I wouldn't say it's that long. The biggest, I think, holdup is, if patient doesn't, if we don't have any of your records, just getting your records so that we can properly evaluate you. The biggest is imaging. They are working on a way to send you a link to upload. I know that that's been a long process that they're working on. So that's something that I was told recently is they think is going to start very soon, where they could send a link to you. And if you have a CD, you could upload it yourself so that we don't have to mail things. But sometimes the imaging centers, or they'll have all these like encrypted images, and it'll give you errors when you try to upload it because they have it like password blocked and stuff. So, sometimes it's, easiest just to mail it to us and we can try to figure out the encryption to get the images off. So that's one of the limitations. We are basically doing usually every Tuesday. Basically the entire day is just blocked to do telemedicine consults for interested patients for histotripsy. So one of us is usually available pretty much every Tuesday. And so we are seeing quite a number of patients. So I'd say the limitation is just getting medical records, and then whether or not you need insurance authorization. Like I mentioned earlier, if you have Medicare, there's no issues with insurance. So especially if you're Medicare and you're local, if we have a cancellation, you may get called to come in just because we know that there's no insurance issues.
Yeah, I'm on the East Coast, so would New York City be a good place to try?
Yeah, there's 2 locations in New York. NYU and New York Presbyterian are doing the procedure. I know the NYU I went to NYU for medical school. I know the NYU doctor is an interventional radiologist personally. I don't know the New York Presbyterian doctor personally, but I'm sure either of those sites are great to go to. And I just don't have the map off the top of my head of the other locations there.
Mhm.
I know there's a location in Chicago, and I'm sure there's other locations on the East Coast. If you go to the Histosonics website, they should have kind of a more up-to-date map on where
Okay.
all the sites are.
Yeah, I go to Sloan and they don't plan on having this treatment yet.
Yep, perfect. Yeah, there's 2 other sites in New York City then.
Thank you.
I have a question that's, can you hear me?
Yes, we can
Yes.
hear you.
Yeah, I have a question. It's a little off topic. So maybe you're not, don't feel comfortable answering it, but in the chat, I asked, my recent MRI, they couldn't get a good image with the bile ducts. Would the histotripsy diet help them see the bile ducts the next time I get an MRI?
Probably not. What it really does is it gets rid of all the gas that's in your intestines. MRI is not necessarily as affected by the MRI of the liver wouldn't be as affected by air in your bowel. But with the ultrasound, any air blocks all ultrasound imaging. And so that's why we do that. Because we've seen definitely early on patients that had a lot of the colon was filled with air. And it kind of blocks some of the limitations. So I don't think it would affect that. I think there can be a lot of other reasons, but I don't think that would change anything.
As an interventional radiologist, is there any advice you could give me? There's something I can do so that I don't have that problem in the future? Because that was exactly where my carcinoma was. So it was scary that they couldn't see it.
So I'll say, so when things are very small, they're often hard to definitely see, especially in the center of the liver, because there's a lot of different structures there.
Okay.
And so it's, there's not, I don't know if there's anything else, honestly, that can be done other than just following it over time, just to make sure that nothing changes.
Okay, thank you.
Thank you. Any other questions? We have about 2 more minutes if there's any other questions that you might have. And I shared that we'll have this webinar once a month going forward. So you're welcome to rejoin and ask other questions that you might have.
Oh, I didn't catch what the cash price was for people whose insurance doesn't cover it. Was that mentioned?
I don't, yeah, I'm not going to mention it on the call because things change. But the nurse, we've treated patients who have had insurance denials, and we've also treated a lot of international patients who are doing that. And the cash price is going to vary at every single hospital. What I've learned is it's very hard for a hospital to figure out how much something costs. So they finally, come up with a number, but I don't want to say it on here because it does change
Okay.
over time.
So we'll
But
I'll
if
just
you're
call them
interested,
then.
the nurse navigator can talk to you specifically in your case.
Thank you so much.
Someone asked about, do mutations or anything affect? No, this is really purely mechanically destroying anything. So in a patient, we could just turn it on in a piece of your liver and it would destroy that piece of liver. So really whatever we're going after is going to be mechanically destroyed. It's not going to matter the mutations or the biomarkers. That could matter for whether or not you have an immune response to this. But it wouldn't matter. It wouldn't necessarily mean the treatment can or can't be done. All right, I think that it's about 1 o'clock. So thank everyone for joining. It's our first one we did, so I hope it went okay. If there's any suggestions for things you'd want us to talk about, please reach out to Chelsea. I don't know if there's an email people can send things to, but reach out. That way we could add things to our presentation if there's certain topics that maybe I kind of missed over or kind of went over too fast, that we can make sure we tailor this even better for the future.
I'm putting my email address in the chat.
Okay. All right. Thank you.
Thank
Everyone have a
you.
good rest of the
Have a good
week,
day.
and great to have all you on here.
Thanks, Dr.
Bye.
Bye.
Thank you, Chelsea, for organizing it.
Of course, thanks for being here. And again, I'll put my email address in there if you guys have any further questions.
Yes,
I'm
that'd
happy
be
to help. Oh, it's .org, not .com. Sorry, I'll put it again. Well, actually, let me see if I could just change it, right? Nope, I can't. There. It's mahsa.evenfar@harvard.edu. Providence.org.